this week on the Back Table Podcast.
Yeah, that's that box where it's tough, and where I think part of the value of the tumor board is, one, is actually having persons of your own specialty there to kind of be a regulator. Because for any surgeon, we have 6 surgeons in our group. It's not a bad idea to have 5 other surgeons go like, what are you thinking? You should maybe dial it back. On the other hand, it's nice to have, the other specialties where a medical oncologist can say, I know that if we can treat this, the outcome's going to be good. They're going to do well with chemoimmuno. Can you find a way to definitively treat this locally? And then you can feel, as a surgeon, a little more comfortable saying, I am going to, in that gray box, I'm going to push a little bit more. It's technically on the edge, but clinically this is going to go well. Let's find a way to do this. Let's take that bigger step. Let's take a little bit more risk operatively, and I think that's worth it. So this is a case from our tumor board. The quick background on her: 75-year-old woman, had prior breast malignancy treated, who landed at her primary with some new dyspnea, carries a few comorbidities, but is actually great functional status, was still working, never smoker, no alcohol, no big family issues that came up. So she got some imaging, and I think the next slide you can sort of see pretty clearly that there's a large mass in the left lower lobe. This thing kind of obliterates the inferior pulmonary vein, and then you can see abutting the airway and the undersurface of the pulmonary artery there. So she got a PET as well, and you can see metabolically active, probably central necrosis there. And then there's a lymph node there at the bifurcation, which is also FDG avid, but nothing really in the mediastinum that looked too bright. So she was sent to our interventional pulmonologist to undergo biopsy and complete mediastinal staging.
Yeah, I think that brings up a big question at this point, because I can say in our practice, I think that this case would be sent to us for a percutaneous biopsy.
Okay.
And that I find highly questionable. I believe that is the pathway that would be chosen, maybe not if a thoracic surgeon saw the patient, because of ease of access and ease of procedure. Order the biopsy, it's reviewed, we schedule this biopsy, it can be done safely, we'll probably get a positive outcome as far as a diagnosis. I look at this case and I see exactly what you described, that there's a lymph node in addition to this mass. And this is a big mass, right? When I look at this mass, initially I think this may not be a resectable mass ultimately, that this patient has a high likelihood of spread of whatever this is to mediastinal lymph nodes. I want to send to an interventional pulmonologist to get simultaneous tissue diagnosis of the lung mass and the lymph nodes. Scott, how do you see this?
Yeah, 100%. I think even if it's radiographically negative, I think that there's a reasonable chance of radiographically occult N1, N2, potentially even N3 disease. And so doing invasive mediastinal staging is absolutely imperative here.
Yeah, this was actually a great case from our side in the sense that this came back to what we started talking about, came from a pulmonologist who then immediately said, look, I've got this individual, I have this imaging, why don't we just see them in the multidisciplinary clinic right up front? And so that way, even before a diagnosis, they saw our interventional pulmonologist, they spoke with our medical oncologist, and they saw me. So we immediately were able to say, well, yeah, the staging plan we're going to need is to go this direction. And so they started out in that multidisciplinary format, and then I think it helped us make the best choices to get a diagnosis, a stage, and then move forward with them. They did end up, of course, getting an MRI. The nice thing in this case is because of some insurance coverage-related delays, this actually took a while to get aligned. So they had already had their diagnosis, but they did have what was concerning for a small metastasis. But this was identified kind of after everything else had already been completed. So the path is on the next slide, but essentially confirmed that this was a squamous carcinoma, but none of the lymph nodes outside of that one level 11, and that is actually what was biopsied for the diagnosis, was that lymph node, to your point. No other spread elsewhere. So what looked to be what we were calling a T4 N1 squamous carcinoma, again, prior to having this brain MR.
I think even with the brain, I think it's a subtle finding, and I don't know that you would forgo potentially curative intent treatment in order to watch this brain. And so I think it's still an appropriate decision.
Can you talk a little bit about that with an isolated brain metastasis in the setting of non-small cell lung cancer and no other evidence of disease, how you generally approach these cases?
Right. And so we're always thinking about TNM staging regardless of the M part of it, because we often get the patients when the metastasis has happened. And then we look at, is this solitary? And the brain is a good example. And when we have a solitary or something not even all that clear on brain imaging, we think of the brain separate and think about what systemically they need and think we can treat the brain if we need to. And we would want them to get the treatment they would get for the rest of the lung disease first, unless it was widely metastatic. So we do think about these oligometastatic patients and look at the T and M and N staging to think about how they might proceed forward.
Are there any other sites in the body?
So if there's an adrenal, anything that's kind of oligo, even a local bone lesion, if it's one, the bone is a little tricky. Often on subsequent imaging, once they start getting treated, they become many. But again, we're looking toward curing a patient if we can, and so that's kind of where our starting point is. I see this as metastatic. Is there a way to get a better outcome for local control? And because I know how to treat somebody systemically, but usually those outcomes are not as good as if we can get the local control too. And so we're always looking for that. And it's so usually solitary mets, we will at least consider it. I think liver is a place where we probably start to treat systemically and not try to do local therapy and, treat the liver, because the liver tends to be something that has more implications for higher level of metastatic disease.
How do you feel about nodal involvement when you're thinking oligomet? Because we always, as surgeons, are kind of on the fence where if I see nodal disease, and we've got an isolated brain met, you start to question, should we undergo surgical resection, which comes with a lot more morbidity, or is this someone we shift over to chemoradiation, immuno, and then can treat the brain with cyber? I still treat them that way, but take the surgical morbidity away when we start seeing nodal disease. That's always been my kind of hesitancy, is it really just that sort of, quote, oligomet pattern, or are we seeing local, we're seeing regional, and we're seeing distant? Maybe we should treat them differently.
So I think an N1 nodal disease is different than N2 or multi-station N2 disease. So I think with N1, I would still proceed. Also squamous cell. In our squamous cell patients, they tend to be more, I know this was a large tumor, they tend to be larger, more localized. So I would like to get that local control. If this was a diffuse adenocarcinoma, and then you see these other small pulmonary nodules that we were ignoring, but now there's lymph node positivity and potentially another metastases, that's looking more like this is really systemic disease. So I try to get that local control when we can, but I agree. If you start seeing mediastinal lymph node involvement and metastatic disease, sometimes getting that systemic treatment in, and again, now we have other options with chemo and immunotherapy and with targeted therapies, and sometimes then we're doing the consolidation local therapy later. And so I think we keep everything on the table for patients in ways that we never did before, even in the metastatic setting.
So what are the local treatment options for this patient?
So based on her imaging, local therapy surgically would be some kind of probably complex lobectomy, meaning lobe plus airway reconstruction, maybe a sleeve, based on its abutment of the airway itself. We really try and avoid pneumonectomy for lung cancers in most cases at this point. The morbidity is high and we have other really good therapies. So, but for now, it'd be lobectomy would be the surgical local control that we would offer.
And obviously there's no interventional approach to this, but from a radiation standpoint, what would your approach be?
Yeah, I think I can give you the short answer, but the longer interesting answer is if we say they are M1 and have metastatic disease, and then the surgeon says, well, I don't know what the risk benefit would be compared to the risk given a huge surgery. Let's say they're N2 or something, right? And then they get chemoimmunotherapy. And the question is do we do chemo RT or do we do just radiation alone? Because a lot of these patients, what will happen is they'll get complete response radiographically in the mediastinum. Their tumor will shrink down to something very, very small. And I can just do SBRT to the primary target and not have to worry about, giving 6 weeks of radiation with chemo and causing them all sorts of toxicities. And then also potentially they could stay on their immunotherapy for the 5 treatments of radiation or 3 treatments of radiation I'm doing. So it gets a little bit more nuanced for these cases. Like I said, these are the most complicated cases, right? Because there's no guidelines and there's no, studies for this particular patient that has a metastatic lesion that we then get chemo IO and then they have a good response. And then what do we do? The long story short, I would do consolidation, radiation, or radiation up front. I think another interesting question is like, if this were my family member or myself in this exact situation and they have an M1 lesion, I would want them to get chemoimmunotherapy, I think. Whether that's because they're going to get surgery or because they have metastatic disease, I feel like in my heart of hearts, that's probably the best thing for them. Going straight to Pacific and then doing SRS to their brain lesion, I don't want to say that that's the wrong thing to do because we don't have data really. But I feel like the chemoimmunotherapy up front is going to move the needle the most for patients. I don't know how you guys feel about that.
I mean, this is a patient, when I see a large tumor, even before the lymph node was positive, my thought is, please send this patient to me because I think I can help this patient. Now we see it's squamous cell. They tend to have even better responses with immunotherapy. We don't know the PD-L1 status of this, but regardless, we would advocate for a neoadjuvant approach in this patient and give them neoadjuvant chemoimmunotherapy and then hopefully take them to surgery for a path CR, right?
Yeah, so she had liquid biopsy and she had NGS because this is another, to your point earlier about biopsy samples and tissue, this was done on her lymph node biopsy, but they could not do everything because there just wasn't enough tissue. But yeah, looks like someone who would do okay with the immunotherapy. So.
And for squamous cell, the next generation sequencing is less important. You don't expect, unless this person was a non-smoker, you don't really expect them to have EGFR or ALK, which are things that could change their therapy and their outcomes. So that's a very reasonable thing.
Are these patients always getting a liquid biopsy up front? Is that something you're doing these days?
So patients with early stage disease, liquid biopsies are not always informative. Then we can talk, MRD is going to be a whole nother conversation and not probably part of this group. But liquid biopsies are kind of uninformative in most people with lower stages. We're not at the place where we have ultrasensitive assays at this point. So they're better for metastatic disease.
Yeah, so this was just kind of the discussion we had again. She's appropriate for resection. Here's our stage. Are we calling her a 4A, a 3A, and then the options that we kind of had. And we landed on, again, what we were talking about, a neoadjuvant approach, chemoimmuno. The brain, actually, I didn't include it in this, but she had a repeat brain MRI about 6 weeks in, and the lesion's not visible. So whether it was treated or not there, I don't know. We're going to just push forward either way with a sort of curative intent therapy.
What was the response on imaging? Do you have that?
Oh, I don't. I didn't put everything together quick enough.
So you're always, at what time point are you going to get a follow-up imaging study?
So 3 months post-resection, typically, they'll get some 3 to 6, just kind of depending on.
And do you tend to do imaging? So now they're getting 4 cycles neoadjuvant. I think there's some question whether there's a benefit to looking at a scan in between, again, especially with the pseudoprogression and things like that. I'm not a big fan of getting a scan in between. I'd rather just do the therapy and move on because I'm not sure that it should stop you from giving more therapy.
I don't, unless we have a really high expectation that there is something, either they're progressing and truly progressing, maybe they're not tolerating the therapy, or we're just concerned. Otherwise, I don't have any reason to look, just wait till you're done. Don't look inside the box, and then we'll deal with it.
So you're not concerned about a patient, about uncovering more widespread metastatic disease that would certainly sway a decision for a definitive local therapy?
Well, we would image them after completion of their systemic. So yeah, but we wouldn't do the kind of the 2-cycle re-image and then see where we're at, and then 2
We're seeing more and more of them do it because in a standard metastatic setting, you might image after 2 cycles. And so that's kind of where people are going. And I've seen a lot of these now where then they end up coming back to tumor board because they don't look definitively like they're responding.
Right.
And to me, that's insufficient. And once you decide on that neoadjuvant approach, you're going forward with it. You're not going to stop it halfway and then have to, convert it to chemoradiation or something like that.
What about your borderline cases? Because like the threshold for saying that they're operable, right?
So, I think it's a good question. And it kind of, I'll give a really long-winded surgical answer. So I think resectability is something that comes up a lot. People, I think, use the term unresectable surgeons include it inappropriately because they assume it's just sort of a linear, it's a line of unresectable, resectable. But really, resectability is a plane. There's two axes of it. There's clinical resectability, and there's technical resectability. Clinical resectability is, will my operation benefit this patient from the perspective of their disease burden? And so the answer is, even if you have a very small lesion with N3 disease, surgery is clinically not you don't do that. That's a clinically unresectable tumor, right? Technically, sure, you can take all that out. That's not very hard. Technical resectability is the other piece of it. Technical is, can I do this operation and have a patient walk out the door, a whole patient walk out the door? And that's a different thing to approach. So how extensive is the disease? So when I think about resectability, I'm thinking about those two axes. So you've got technically resectable, clinically resectable. That's an obvious yes. You've got technically unresectable, clinically unresectable. That's your obvious no. The gray zone is on either side. If you have a patient who is clinically resectable, where you feel like you can benefit, like this patient, we can benefit them if we can provide a definitive therapy. But technically, you're pushing a limit. Can you get them through this operation? And so the question is, well, am I going to get them through a lobe? I think so. A 75-year-old woman can get through a lobe. A sleeve? Yeah. Airway reconstructions are fairly straightforward. We can do that. A pneumonectomy? Are we going to believe that this 75-year-old is going to push through it? Well, it's a left side, probably okay. A right side, maybe not, higher morbidity. So yes, it is a resectable tumor, but we're pushing the limits of it. The other side of it is obviously the ones that are clinically technically unresectable, but clinically you do well. And so those are the harder decisions for us, is you want to, as a surgeon, push really hard to do it, because you say, look, this patient, it would be great if you could get this out. They're going to do well, but technically you're saying it's involving too many structures. Maybe you've got, aortic involvement, for example. That's resectable, but it starts pushing the difficulty level a bit. Will the patient tolerate it? So those two boxes of where it's discordant between the clinical and the technical resectability is what makes it hard. And then, like any good surgeon, I'll fall back to the radiation oncologist.
Yeah. Yeah. Well, because I find myself pushing patients towards surgery because I feel like they're going to get chemoimmunotherapy, and that seems to help the patients the most based on all the cases we reviewed in the past. So if they're technically resectable and clinically, that dial can be turned up, where it's like in one, in two, multi-station in two, maybe like limited in three or something.
Yeah, that's that box where it's tough, and where I think part of the value of the tumor board is, one, is actually having persons of your own specialty there to kind of be a regulator, because for any surgeon, we have 6 surgeons in our group. It's not a bad idea to have 5 other surgeons go like, what are you thinking? You should maybe dial it back. On the other hand, it's nice to have, the other specialties where a medical oncologist can say, I know that if we can treat this, the outcome's going to be good. They're going to do well with chemoimmuno. Can you find a way to definitively treat this locally? And then you can feel as a surgeon a little more comfortable saying, I am going to, in that gray box, I'm going to push a little bit more. It's technically on the edge, but clinically this is going to go well. Let's find a way to do this. Let's take that bigger step. Let's take a little bit more risk operatively. And I think that's worth it.
Yeah, because like from a radiation standpoint, the answer is always yes, right? If anyone ever asks me, can you radiate this patient? I'm like, well, yeah, I can. The only difference is how many days I'm doing it, how high is the dose, what organs are nearby. Obviously, the technical component is extremely, complicated, but the clinical, question is usually because they're not going to get surgery. They're running out of systemic therapy options. So, clinically, like, yeah, I can always get radiation, or, it'll usually cause the tumor to get smaller.
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.